Good evening, good evening. Tonight is everything about pneumothorax and your procedures that you've been waiting for, chest tubes and thoracentesis. I really like that I'm making this episode its own episode because chest tubes are my favorite procedure to do, and I do them frequently. I think that pneumothorax is deserving of its own special episode where you can kind of use it to then compare and contrast. The next episode I'll do will be post-op complications to include a focus on post-op pneumonia and then lung malignancies and et cetera, et cetera. But for tonight, we're staying focused and on track with pneumothorax and going through the definition, the different types, and how to manage them. For our study tip for tonight, I can't really think of one off the top of my head. I think that something that's been on my mind lately is remembering the power of taking breaks. For example, I am somebody who did a terrible job of taking breaks. And once I started forcing myself to get up from the desk I was sitting at and walk around, even for 5 minutes, I noticed that I felt much more focused when I came back. Perhaps that means I'm just getting a little bit older and I need more break time before I can stay focused and jump back into things. Maybe I never could have done that, and when I was pulling all-nighters in college, I shouldn't have been. I don't know. But I would recommend just trying to take even a walk around the hallway, up out of the school, get up, go grab dinner, anything you can do to get yourself out of the jitters, whether that's doing 5 jumping jacks or playing a song or watching 5 minutes of mindless TikTok. Do something for even a short period of time to get yourself out of your own head and then refocus in. That's my study tip for this week. Okay, let's go ahead and jump right into everything. Oh my gosh, I almost just choked on air. Okay. Pneumothorax is an accumulation of air in the pleural space. If you remember last week, pleural effusions was all about fluid accumulation in the pleural space. This week it's about air. If you can imagine a house or a room with a balloon that fills up the entire room all the way to the edges, that is normal. Now, if you open a window to that room and air is forced in, I don't know, there's like a tornado outside or something, you push air in, you can imagine that the balloon then starts to get compressed, and pushed away from the edges of the wall. That is essentially what a pneumothorax is. There are 4 types that we're going to discuss: a primary spontaneous, secondary spontaneous, traumatic, and tension. I like to remember these because the spontaneous are related and then the traumatic and tension is related. So I remember them as the S's and the T's. There's 2 S's, there's 2 T's, there's 4 to remember. The 4 types and then the etiologies of them are how I'm going to start the episode, and then we'll go into the presentation, we'll go into diagnostics, and then we'll go into treatment, and then I'll do a little tidbit on tension pathophysiology as well. As far as the types of pneumothorax, first up is primary spontaneous. This is a pneumothorax that is atraumatic and idiopathic without underlying lung disease. Okay? Atraumatic, idiopathic, no underlying lung disease. The difference between that and a secondary spontaneous is that it is atraumatic, idiopathic with lung disease. Primary is no, secondary is with. The etiology of a primary spontaneous pneumothorax is due to bleb rupture, and this occurs in tall, thin men ages 20 to 40 who also usually are smoking cigarettes. Secondary spontaneous pneumothoraxes occur in patients who have comorbid conditions such as COPD and asthma. So that's the difference between your patient vignette that you're going to get and the etiology and the type of pneumothorax. So I think keeping them together and then comparing and contrasting them helps you put together a picture. They are not going to ask you if a 17-year-old male who has, a sudden pneumothorax out of nowhere, they're not going to say, oh, well, is this a primary or secondary spontaneous? They're going to make it very clear that that would likely be a primary spontaneous pneumothorax as opposed to a secondary. They're going to be very clear that this patient has chronic asthma, this patient has COPD or cystic fibrosis or some other underlying pulmonary disease that's going to make it very obvious. Now, a traumatic pneumothorax is due to either trauma or it's iatrogenic, meaning caused by something we did medically, for example, versus blunt force or penetrating trauma due to an MVC, a gunshot wound, a stabbing, something of that nature, versus things like that could be iatrogenic, such as CPR, mechanical ventilation, placing a subclavian line, or performing thoracentesis for a pleural effusion. Those things can all cause a traumatic pneumothorax. Now, a tension pneumothorax is any type of pneumothorax when positive air pressure pushes the trachea and great vessels to the contralateral side of the pneumothorax. So away. So it pushes it away. So if you have a pneumothorax on the right, the trachea is going to be deviated to the left. Okay? You're going to probably want to look up a picture of this because it's kind of hard to describe, but that is tension. Tension is when things become emergent and can be deadly and life-threatening. That is the ring, ring, ring one that you're going to be doing something emergently, usually. The tension pneumothorax pathophysiology is a bit unique. Essentially, a valve effect is created and it becomes an acute issue. So when the patient inhales, outside air enters the chest, and then on expiration, the valve closes and air cannot escape, which causes the lungs to continue to collapse, and push the other side. So remember that analogy with the giant balloon in the room and the windows open. Imagine they're like French doors that are open and they're rushing in, but then the doors flap close every time you try to push it out. You can't. So then the balloon keeps getting squished, and it's being forced through the only opening, which is a teeny tiny door on the opposite side of the room. That is essentially what's happening in a tension pneumothorax. Presentation-wise, typically it is the development of chest pain and dyspnea in a patient at rest. It can be asymptomatic. If it's traumatic, oftentimes there is an inciting event, and you are pretty clear that the patient's having shortness of breath, dyspnea, chest pain, things of that nature are going on. On your physical exam, this is important. If you remember last week, pleural effusion, everything was down. I spend a little bit of time talking about how water or fluid in general is going to be a little bit more dense than air. That's important for this week. The difference presentation-wise between percussion, fremitus, and breath sounds is that everything is decreased except for percussion. Because remember, if you're tapping on a balloon, that's going to sound different than if you're tapping on a water balloon. That's what I like to imagine. Some people, even in my cohort, would put water in their mouths and then like pop their cheeks and then do it with just air in their cheeks, and that was the difference in sound. And that's how you could remember that there is hyper resonance on percussion, and then everything else is still decreased. Fremitus is decreased, breath sounds are decreased, blah, blah, blah. Vital signs, these patients are often tachycardic, they're tachypnic, they are hypoxic, they're hypotensive. Those are kind of your common vital signs when things get a little bit more severe. Things that are red flag symptoms are asymmetric chest rise, subcutaneous emphysema, tracheal deviation that you can see, and of course, worsening hypoxia. Etiology, we've kind of reviewed already, so I'll go right into our diagnosis. Chest x-ray is your initial test of choice, which was the same for pleural effusion. On this chest x-ray, you're going to see a couple things. One, decreased peripheral lung markings. There's going to be two lines, which is actually called a companion line. One is the line that runs parallel with the ribs, and then right next to it is the visceral pleural line, and there's space in between that's filled with air. The next sign that's important is deep sulcus sign, so that costophrenic angle that we talked about, which was blunt. This is kind of like the opposite effect, so it's very deep and very acute, and it goes down much further than you would anticipate it to. Those are things you're going to see on chest x-ray. You can also get an ABG, which is going to show hypoxemia, a respiratory alkalosis, possibly compensated, possibly not. EKG often has an MI picture, which is interesting. That's more of a fun fact. I don't know that you're necessarily going to get a question about that, but I think it's important to know. Treatment, of course, if it's small, then you're going to be doing O2 therapy and observation. If it's large or greater than 3 millimeters, you're going to be doing a needle aspiration versus a chest tube, depending on the situation. For the next little section of treatment, I tried to kind of simplify this as best as I could for this section, and then I'm going to spend a little bit of time talking about traumatic pneumothorax because that's something I treat all the time. But for the purposes of your test, just remember if it is small, it's just oxygen observation. If it's large, needle aspiration versus chest tube, depending on if the patient is stable or not stable. for a stable secondary spontaneous pneumothorax. Remember, the secondary spontaneous pneumothorax are the patients who are idiopathic and atraumatic with lung disease. Those patients get a chest tube and hospitalized. If there is tension pneumothorax, the boards say you do a needle aspiration followed by a chest tube and hospitalization. In that order for your boards. Okay? There are some complications. You can do, some things can develop like subcutaneous emphysema, which I've mentioned before. That's when you get Rice Krispies underneath the skin. So imagine a bunch of bubbles kind of develop, and then when you press on the chest wall, it feels and sounds like Rice Krispie treats. And then things like pneumomediastinum. And then, of course, we talked about how tension pneumothorax can actually be deadly. Prognosis, it's very common for pneumothorax to recur even after a chest tube treatment, but it's uncommon to occur after surgical treatment. So there are times when you're getting a cardiothoracic surgeon involved. That's when it's very uncommon to have recurrence. Patient education, once patients have had a chest tube, you want to, or a pneumothorax for that matter, you want them to avoid increased pressure gradients. So think things like high altitudes and scuba diving. So anything that's going to have great pressure changes, you want them to avoid that for around 4 to 6 weeks, sometimes even longer, depending on the severity of the pneumothorax. Okay, that's basically my rundown of the very simple board exam questions. If you're interested, which I hope you are, I'm going to very briefly discuss traumatic pneumothorax and what the perfect, or I guess not perfect, the common clinical picture of a patient who's coming into a trauma bay. Oftentimes, these patients are coming in on oxygen via a nasal cannula and they're still hypoxic. They're complaining of chest pain. Let's say, for example, there's blunt trauma to the chest and, for example, a patient was ejected from a vehicle and now they're coming to the emergency room. They enter the trauma bay. They're hypoxic at maybe 89% on 6 liters of nasal cannula, complaining of shortness of breath and chest pain. That's all they can talk about is their chest, their chest, their chest. You can tell that they're working a little bit harder to breathe. And when you do your trauma assessment, you do the ABCDE, so airway, they're talking to you, so you know you're okay for a little bit. Breathing is what you assess next. Here you're saying, okay, they're maybe 86% on 6 liters now, so you put them on a non-rebreather mask and they're still hypoxic. You're like, I don't know, this is something's going on here. When you put your stethoscope on their chest, you realize that they have no breath sounds on the right, and you realize that they're having lots of Rice Krispies on that right side and a lot of chest wall tenderness. Left side, you have some breath sounds. Everything looks okay. There's no tracheal deviation, nothing like that, but they're still hypoxic. You move through the rest. Here, you're kind of like empirically thinking you may need to place a chest tube. So there's oftentimes you're wearing lead and there's usually like a chest x-ray board right underneath the patient. So I usually just start prepping for a chest tube while they're snapping a chest x-ray because I know I'm about to place one. Once you confirm the pneumothorax on chest x-ray, which oftentimes in this situation, let's say there is one, then you place your chest tube right then and there. That is reality. We don't really do needle aspiration in the trauma bay. That is more of a pre-hospital setting procedure. But for your board exam, that's not what they're asking. They want you to know that if there's an unstable patient with a suspected pneumothorax, you needle aspirate or needle decompress, and then you do the chest tube. In reality, I don't even know that I've done a needle decompression. I've only done chest tubes, and I do them quite frequently in the trauma bay because I can do them pretty quick. The point is that you could do a needle decompression very quickly and have symptom relief and kind of ward off any tension physiology that might develop, whereas somebody like myself who has some experience under my belt, I can place a chest tube fairly quickly in the same amount of time it might take somebody else to put a needle in. Generally speaking, that's kind of the thought process. I'm going to go ahead and refocus us in, go through our procedures, and then let you guys be done for the night. First up, thoracentesis is what I want to talk about first. This is relevant for pleural effusions, okay? So that's kind of what the focus is here. What is thoracentesis? Thoracentesis is a percutaneous procedure to remove pleural fluid through either a needle over a catheter, or a small bore catheter. It's usually an inpatient procedure, and usually you're asking IR to do it. Oftentimes you can do it yourself, but usually we have IR do it. Indications are either diagnostic or therapeutic. Diagnosis of effusion of unknown etiology or therapeutic to provide symptom relief. There are some contraindications. One is if there's not enough fluid to aspirate, then you really can't do it. If there is a skin infection at the needle insertion site and there's nowhere else to go, oftentimes that's an indication, that's a contraindication, but it's not necessarily a absolute contraindication, it's a relative one. One thing to note for this is that mechanical ventilation is not a contraindication to a thoracentesis. There is no reason why you cannot do a thoracentesis just because your patient is being mechanically ventilated. Generally speaking, they think that that mechanical ventilation, the thought process was that it increased your risk of pneumothorax, but the data is just not really there, particularly if you're doing an ultrasound-guided procedure, which is what I'm going to describe next. How do you do a thoracentesis? I'm going to talk through an ultrasound-guided one. That's what I think is most common when we're talking about thoracentesis, and I think it's the most interesting, so that's kind of what I want to talk about. It's very, the procedure, even if you're doing it maybe a different way, the thought and the general steps are pretty much the same, so I think it's okay to kind of take you through this one. Of course, this is a sterile procedure. You're going to gather all the materials you need. Often things come in kits, put your PPE on, patient positioning, blah, blah, blah. Some of that stuff I think is simple. I'm not going to go through the details. Next, you're going to want to select your site. So first, you're going to visualize with the ultrasound and perhaps correlate with the CT scan to identify where the fluid is. Where the fluid is and what kind of fluid is going to slightly determine the site that you pick to do the needle. If it's free-flowing fluid, you're going to want to pick an intercostal space that allows the needle to be inserted perpendicular to the chest wall into the fluid and not lung tissue. And if it's loculated fluid, which you can usually tell on ultrasound, you may want to kind of find a space that lets you change your angle just slightly. Next up, once you have your site selected, you're going to want to do some local anesthesia. You're going to anesthetize the skin. Then you're going to go a little bit deeper to the subcutaneous tissue, down to the periosteum of the rib you've selected, and then even further to the pleura and the pleura nerve endings. Once you do that, you actually oftentimes can slip your needle just slightly further into the pleural space while you're aspirating to confirm your location. Prove you're in the pleural cavity, and it gives you a hint of what kind of fluid you're going to be aspirating. Once that's done, the patient's all numbed up. You make a small longitudinal incision with a scalpel. In this situation, I'm doing a needle catheter or over-the-needle catheter. So you're going to insert your needle with the catheter over top while applying continuous negative pressure on the syringe, which is attached. Once you aspirate fluid, you insert the needle 5 millimeters additionally. Hold the introducer stationary while you're inserting the catheter forward. Remove the needle so there's nothing sharp in the patient. Collect some seral samples, and then if you still have fluid that needs collected, which oftentimes you do, you can place your catheter tubing to gravity. You can syringe drain it, or you can vacuum bottle drain it. Oftentimes, we don't necessarily have to leave a drain behind, but sometimes they do. It just depends on the situation. Just know that there's an option to leave a drain behind or just aspirate, remove the fluid, and call the procedure done. Complications of this procedure. The most common is pneumothorax. However, ultrasound-guided procedures significantly reduces the rate of any kind of pneumothorax that occurs. I think I found a data point on UpToDate that said 3%. Just know that's the most common, but even that is rare. Some other complications are the simple things: infection, damage to nearby structures, and bleeding. So liver or spleen puncture or bleeding from the skin, subcutaneous tissue due to coagulopathy or because you punctured the liver or spleen. Think about things like that. I like to always simplify stuff. So for a lot of these procedures, it's infection, bleeding, damage to nearby structures. That's usually a good rule of thumb. Next up, we're going to move into thoracostomy tubes and needle thoracostomy or needle decompression. First up, what is a thoracostomy tube? This is known as a chest tube. This is what we're talking about when we say we're placing a chest tube. It is a thoracostomy tube. It is placed through the chest wall into the pleural cavity to either drain an indication, such as air or fluid, or instill medication, such as in the case of a refractory pleural effusion. So you can actually do some therapeutic stuff with this type of procedure. The most common indication is for pneumothorax. However, this can also be used to drain hemothorax in the setting of blunt or penetrating chest trauma, other pleural effusions, or pleurodesis, that's the name of what we call the installation of sclerosing agents or other medications. So that's pleurodesis. It's kind of when you're washing out the pleural space, so to speak. Now, contraindications, there's not really many. There's not a ton. You can even do these on neonates. It's kind of a I couldn't really find many absolute contraindications. Some relative ones would be things like skin infection, coagulopathy, or anticoagulation, which is going to increase your bleeding risk. But again, if this is an emergent situation in an unstable patient, you're usually just going to do it. Needle or finger thoracostomy is kind of what I want to talk about first before I get into the procedure, because I think that it's important to know how to do it and when to do it and how the boards want you to view it. So needle thoracostomy is often used in the pre-hospital setting, specifically when tension pneumothorax is suspected. Now, the signs and symptoms you're going to see in the pre-hospital setting are going to be things like acute respiratory distress, like hypoxia that you can't recover from, even with nasal cannula, asymptomatic breath sounds, as in lack of breath sounds entirely, or asymptomatic chest rise, subcutaneous emphysema, tracheal deviation, hypotension, tachycardia, really tough clinical picture, plus an indication or sign or inciting event like blunt or penetrating trauma to the chest. In that setting, we like for healthcare providers to use a 14-gauge angiocatheter in the second or third intercostal space in the anterior or mid-axillary line. That's what we usually like to use. It's better to use it there as opposed to like the first or second space in the mid-clavicular line, which I think used to be a recommendation. Nowadays, we like for people to use like the third or fourth intercostal space on that mid-axillary line for it, because there's less of a risk of causing a pneumothorax if you're wrong, or less of a risk of bleeding because you're a little bit further away from major structures. You can also, like I said, that third or fourth intercostal space, you're often using a longer needle there, but that is another option. But generally, we'd like a 14-gauge needle, second or third intercostal space, anterior mid-axillary line. That's where we like to do it. Okay, in the boards, if you have an unstable emergent patient with a pneumothorax, first-line treatment is a needle thoracostomy. Once the patient is stabilized, you place a chest tube. Okay, I'm saying it a million times. Don't forget that. Procedure. So the procedure for a chest thoracostomy, I want to be clear that there are different techniques out in the world and people do things slightly differently. I'm giving you a general overview of the most common technique or most basic technique that I think you're going to see, which is the blunt dissection technique. There is the Seldinger or percutaneous technique, which is minimally invasive. You're using a smaller diameter catheter when you're doing that. There's a lot of data to show that you actually don't need to use a large bore thoracostomy tube in order to, even in the traumatic setting. However, I think for the purposes of this podcast, I'm just going to go through a blunt dissection technique using the standard tube size. So the tube size that you're going to select is something greater than 16 French. Usually in a traumatic situation, we're using a 32 or 36 French tube. Obviously, you're going to have to use what you have available, but that's kind of what ATLS recommends. This is, again, a sterile procedure, and you need to prep yourself and the patient. As far as the patient, generally, we like to pre-oxygenate them. So if they're on nasal cannula, perhaps we put them on a non-rebreather. We're giving them a lot of oxygen to kind of pre-oxygenate them as best we can. They must be in the correct position, and we usually try to anesthetize them appropriately as best we can. These can be very emergent situations where you don't have a lot of time, and perhaps your patient is already intubated in a traumatic situation, or you're in a trauma code where the patient currently does not have a heartbeat, doesn't have a pulse, and compressions are being done actively. There is a place for resuscitative chest thoracostomy as an attempt in the setting of blunt or penetrating chest trauma. Again, these are kind of unique situations that I don't think you're going to get board questions on, to be honest, so I'm not going to go into that. Next, once you have everything ready and you're good to go, you've pre-oxygenated your patient, you have all your supplies, you yourself are dressed up, your patient, usually we like to have them laying flat on their back with their arm kind of, externally rotated and lifted above their head. The location is super important for this procedure. I want you to know this. The location is going to be the fourth or fifth intercostal space on the anterior axillary line. How do you know where the anterior axillary line is? Well, you're going to want to find the nipple level on males and the inframammary fold on women, and that's how you're going to find, kind of go across and then find that mid-axillary line, and then right where those two lines meet, that's where you want to place. That should be the fourth or fifth intercostal space. Now, the other question that I think you could get asked is, do you go above the rib or below the rib when you put a tube in? The answer is you go above the rib. Why? Think about it. Anatomy. It's coming back. Okay. Do you remember a intercostal bundle, vein artery nerve, that lives right below every single rib? That's why. So you want to avoid that and go over a rib when you put a chest tube in. Bear that in mind. That's all for location and insertion tips. Those are the things that I think you're going to get questions on. Once you've identified your location, you're going to once again anesthetize the skin, subcutaneous tissue, periosteum of the rib, the intercostal muscles, and the pleura. Once again, you can aspirate and just go a little bit further while you're doing this to aspirate either blood or air, depending on the situation. And then you can kind of confirm your location that way. Once that's done, you're going to remove that, create a small longitudinal incision, probably I'd say 3 centimeters in length, and then used a curved clamp to dissect and hold your clamp near the tip in order to ensure that you don't accidentally go in the chest cavity when you don't mean to. When you are ready to enter the chest, you're going to use a clamp in the closed position to ride over the superior portion of the rib and go kind of just hook over that rib and enter through the pleural pleura. Once you are in, you're going to open the clamp and spread the intercostal muscles and parietal pleura. At this point, you should get a rush of either air or fluid. If there's a massive hemothorax, you're going to get blood. If there's a massive traumatic pneumothorax, you're going to get a rush of air. Then you're going to insert a finger and confirm placement. There's less of a move for a true finger sweep nowadays, but put your finger in to ensure you're in the right place. After that, clamp your thoracostomy tube at the end and insert the tube through the tract and into the pleural space. When you place the tube, you want to direct it apically, meaning towards the head is the best way to describe it. If you're suspicious for a pneumothorax, you want it to go anterior. If you're suspicious for fluid, posterior. Gravity, just think about gravity. And then you're going to remove your clamp and confirm placement by observing condensation within the tube or titling if there's fluid in the tube when the patient breathes. Once the tube is in, you're sure that it's in the right spot, suture it into place and connect it to suction, and then get a chest x-ray to confirm placement. Now, next up is kind of the maintenance of a chest tube, which I'm just going to very briefly mention. This is going to be placed to suction or an antrum most often, so you're going to have different connections that you need to set up, and you want to make sure that all these are airtight because that can cause an air leak and actually be counterproductive to your efforts to resolve a pneumothorax. It can actually just continue a persistent pneumothorax, so make sure the chest tube is set up appropriately. Once the chest x-ray confirms placement, bada bing, bada boom, you've done a chest tube, and you're the best. Now, the most common complication for a chest tube is malposition, as in you put it in the wrong spot. It's either not hitting where it's supposed to hit, or you put it like in the wrong spot. Sometimes you can insert it into the subcutaneous tissue. You're not even in the chest cavity. You'd probably know that pretty early on. And then some other common complications are infection or organ injury. So again, nearby structures. Think about that. Infection, bleeding, damage to nearby structures. That's how you can kind of remember your complications for most procedures, to be honest, especially in the surgical world. Okay, very briefly, let's go ahead and just do a quick little pop quiz because I don't want anyone to miss a single pneumothorax question. What is a pneumothorax? Accumulation of air in the pleural space. What are the 4 types of pneumothorax? There are 4 types of pneumothorax. What are they? Primary and secondary spontaneous, and then traumatic and tension. Okay, in a tension pneumothorax, does the trachea get displaced contralaterally or ipsilaterally to the pneumothorax? Contralateral. Okay. What is the test of choice in a suspected pneumothorax? Chest x-ray. Okay. If you have a tension pneumothorax and an unstable patient, what is your treatment of choice? Needle decompression followed by chest tube once stabilized and hospitalization thereafter. Okay. For thoracentesis, what is the most common complication? Pneumothorax. Great. Thoracostomy tubes, what is the most common indication? Pneumothorax. See what I did there? Okay. When you do a chest thoracostomy, what is the location? The fourth or fifth intercostal space. Great. Do you go above or below the rib? Above. Yay. Okay. And then generally speaking, for complications of procedures, what are you thinking are your 3 most common complications? Infection, bleeding, damage to nearby structures. Wonderful. I hope that you enjoyed my little pop quiz that I gave you guys. Maybe we'll do that more frequently. Maybe we can start doing them at the beginning of the episodes. I don't know. I just think it made sense for this podcast, so we'll do that. All right. Looking forward to seeing you guys next week, and make sure to leave me any questions that you guys have. Bye.